Welcome to the deep dive. This is where we take a pile of research and boil it down to what really matters for you.
That's right.
So today we're getting into something fascinating, but wow, is it complex. We're talking about how we actually put a value on different health states.
Specifically using a method called time trade-off, or TTO.
Exactly. Now, you'd probably think, okay, a core measurement like TTO, it's got to be pretty standardized, right?
You would think so, but the sources we looked at show something else.
Yeah, they reveal this pretty significant challenge.
Yeah.
Even when different studies use the same basic TTO idea, the health values they come up with can be completely different all over the map.
Which is a huge problem.
Right.
Yeah.
So that's our mission today,
Yeah.
to unpack why this incomparability exists and, why it matters so much for actual healthcare decisions.
Especially when you're calculating things like a quality-adjusted life year, a QALY. That's fundamental.
Okay, let's dig in.
It's really interesting because the QALY is supposed to be this, universal benchmark for comparing treatments.
Yeah, across different diseases.
But if that quality adjustment part, the Q and QAY, is built on such shaky ground, well,
It's like building on shifting sands, as you said earlier. That variability is what we need to understand.
okay, so TTO itself, the core idea.
Right, it's basically about a trade-off. Length of life versus quality of life.
Simple enough concept.
You imagine living, say, 10 years in a less than perfect health state, then you have to say how many fewer years in perfect health you'd accept to be, like, indifferent between those two options.
That's the trade-off. Find the point where you just don't prefer one over the other.
Sounds straightforward.
It does. But while everyone agrees on that core principle, how researchers actually get to that indifference point, that varies a lot.
And the sources really break these differences down, don't they?
Yeah, into sort of three main buckets: methodological, procedural, and analytical variations.
Okay, so these aren't just small tweaks. They really shape the final numbers. Let's get into the first one. Methodological variations. What does that cover?
Well, a big one is how you handle valuing health states that people consider worse than dead, WTD states.
Right, because the classic TTO, it assumes the state is better than being dead. It gives a positive value.
Exactly. So for WTD, you need special methods, like something called lead time TTO. You imagine some time in full health before the bad state.
Okay.
But what's really fascinating, or maybe worrying, is that the way you frame these WTD questions, the specific method you use, can introduce framing effects.
Meaning the phrasing itself nudges people.
Yes, it can subtly push people towards lower values, kind of dragging down the score almost unconsciously.
Wow. So if I'm comparing two studies and they just use different WTD methods.
Their results might not be comparable at all, even if they're looking at the same health state. The difference could just be the method, the frame.
That seems fundamental.
It is, and there's more. Even the time frame you use in the question, like asking about 10 years versus, say, the rest of your life, that can change the values too.
But shouldn't it be independent, according to the QALY model?
Theoretically, yes, but the actual studies, they show mixed results. Sometimes it matters, sometimes it doesn't, sometimes values even go up with longer time frames. It's messy.
Okay, so the core methods have built-in variability. What about the next category? Procedural variations. How the study is actually done.
Yeah, this is about the practicalities, like the mode of administration. How do you actually ask the questions?
Face-to-face versus online, maybe?
Exactly. Face-to-face interviews, great for quality. You can explain things, check if the person understands, see if they're really thinking about it.
Right.
But they're expensive, and you risk interviewer bias, the interviewer subtly influencing answers.
Okay, and the alternative? Internet surveys.
Tape? Easy to get large numbers, but you lose that interaction. No chance to clarify if someone's confused. And are they really concentrating or just clicking through?
Yeah, I can imagine just wanting to get through it, especially with complex TTO questions. That feels like it could really affect the quality of the data for something so important.
Definitely. And then there's who you ask, the sampling frame.
General public versus patients.
Right. Do you ask everyday people to imagine a condition? Or do you ask patients who actually live with it?
What's the thinking there? Patients might know it best.
Maybe. But their values could be different for other reasons. They might have adapted psychologically to their condition over time. That's adaptation.
So they might value it less negatively than the public imagines.
Or maybe they might give answers they think will influence policy in their favor. That's called strategic misrepresentation. It adds another layer of complexity.
Okay, so method, procedure. What about the last bucket? Analytical variations. How the numbers get crunched afterwards.
This is crucial too. Think about exclusion criteria. Who gets left out of the final analysis?
Yeah.
Like people called non-traders. These are respondents who just refuse to trade any time at all. You ask them how many years they give up for perfect health, and they say none, 0.
Because life itself is valuable, regardless of quality.
Perhaps. It might reflect a really deeply held belief. But some studies just exclude these responses.
Is that okay, though? Doesn't that ignore a valid perspective on the value of life?
That's the debate. There's no consensus. And then there's time preference. How much we value health now versus health in the future. Do we discount future health?
Most economic models say we do.
We probably do, yes. But many TTO analyses just ignore it. They don't adjust for it, which can lead to underestimating the TTO scores.
So taking all this together, these methodological choices, procedural details, analytical decisions, what's the bottom line for someone trying to actually use these health values? A policymaker, maybe?
The bottom line is, it makes comparison incredibly difficult. You might have 2 studies on the same condition, but because they made different choices along the way.
Their final TTO values could be significantly different.
Exactly. And it makes it really hard for policymakers to confidently compare treatments or allocate resources based on these values. There's just no agreed-upon valid way to do TTO.
So this deep dive really shows TTO isn't one single thing. It's more like a family of related methods, right?
Absolutely. A family with lots of variations, each with its own impact.
And each impacting the results in potentially big ways.
And, while all this variation, this pluriformity, helps researchers understand the methods better,
It also creates a real headache for practical application.
it really underscores how much we need some kind of harmonization, some standardization, if these values are going to be truly useful and comparable for things like health technology assessments.
Which leaves us with a pretty big thought, doesn't it? If these fundamental measurements, the very basis for deciding the value of health interventions, can vary so much depending on how we collect and analyze them.
What does that really say about the certainty of the big decisions we make? Decisions about our collective health, our resources?
Definitely something to mull over.